All right, we're going to switch gears a little bit now, talk about aortoiliac occlusions. I have a couple disclosures. Let me start out with something that is a fact. Size really matters, okay? There, I've put it to rest for all of you guys out there. So why do I say that? Well, because in aortoiliac occlusions, really the topic is about, in these patients that we're seeing today, no longer are we getting those tiny little occlusions, right? We've really got a couple things that matter in terms of whether or not you can do something endovascular for these patients. And we are all trying to move away from aorto bifem bypass for many reasons, primarily the infection aspect that a lot of us now see because these patients come with wounds. So when I say size matters, what am I talking about here? I'm talking about the bifurcation. I'm talking about that size mattering so much when you move forward with your decision making about whether you want to do a graft, whether you want to do a CRAB, or whether you want to just go ahead and put stents in there. The other thing that very much matters nowadays for us that always mattered but matters so much more today is the fact that you are almost certainly in these patients that usually are about 50, 60, 70 years old going to be coming back at some time to do something, which means you need that bifurcation to look good and potentially, Dr. Sia mentioned earlier he comes up and over. I also am someone who comes up and over a lot. That bifurcation really matters. Not everyone has a Dr. Ankur who can come from the radial and pedal and so in order to do what you need to do to take care of these patients for the next 40 years, ensuring that they keep that that bridge so that you can get in there is really important. So to that end, I'm really just going to talk about 3 examples in terms of management of aortoiliac issues these days. So we're not talking about the old patients. We're talking about what we see nowadays. In this case, 54-year-old female, I'm going to show you a picture in a second, so good thing this is before lunch, who had pyoderma gangrenosum, horrible wounds all over her body, and long story short, complete occlusion of not only her distal aorta, but also bilateral proximal iliacs. So this is what we were dealing with. And of course, the wounds itself on the legs were a problem because her SFAs were completely out. But that's the groin wound. And this is not from any intervention or anything. That's from the pyoderma. But this woman, unfortunately, couldn't heal anything. Bilaterally, she had wounds all the way down. Plus, she could not heal this groin wound because she wasn't getting good inflow. These were her PVRs to begin with. And I'll start the CT scan here just to show you. We'll fly through it. But you can see the occlusion coming up in a second. There, it's out. Both sides out. But then it reconstitutes, But look at how tiny those vessels are. And then, all day long we'd say, oh, great, we just come through the groins. Well, you can't. You can't come through that groin because even though stents do not get infected that often, this one would be asking for it. So in this particular patient's case, the decision was twofold. One, what do we do in terms of getting into the access? And then secondly, what treatment do we do for her? Do we just put stents in or should we put something into that actual area where she had an occlusion? And really that's a little bit of a game time decision because it depends on how your wire flows and what things look like once you balloon, of course. So in this particular patient's case, we got brachial access basically to come down from the side that you couldn't get your groin access on. And then on the right side, we got groin access. So we had a wire coming from the top, wire coming from the bottom. That was the angiogram, so you can see completely out. But I don't know what this stuff was. It's not calcium, right? So that's important because what that means is her BIF is going to be able to open for me. I'm going to have some ability to put something in there that's really going to stretch out. And I'm not worried that I'm going to perforate her. Always, that's a concern. But the less calcium there is, the less likely that's going to be the case. So in this particular patient's case, especially because I knew that I had enough area where once I ballooned, I'd be able to put 2 stents in. And if I had to go up and over on this, I'd be able to do that in the future. So I was happy with that. And I really put the 2 stents in there primarily because then I could come down on both sides and basically open up her SFAs, which is what we did. And then balloon angioplasty that with DCBs and got pretty good results bilaterally. She did go on to heal the groin with a VAC and a lot of care, and so it ended up being the right move for her. Now, moving forward from somebody like this, which is probably not as typical, this is much more of a typical patient. So this is a 66-year-old female. Again, look at the ages, 60s, 50s. All the drama that our vascular patients have, and of course the smoking history and refusal to stop. These were the PVRs to begin with, and starting out, this is what you're looking at in terms of the lesion. Now this is someone I'm scared I'm gonna rip the shit out of that bifurcation if I just go in balloon, right? Terrifying thing. Of course, even though I'm a vascular surgeon, we can get in this and that. Of course, this is a horrible situation. You don't know how it's going to perforate or, it's not a nice little, the iliac just comes off. It's going to be an explosion. So this is someone that I considered a CRAB in. And the reason was because in this particular patient, I wanted to have coverage of that area to begin with and make sure that I didn't have perforation before I put in the 2 interstents. So for those of you who don't know what a CRAB is, it's just a silly name that Gore gave to this technique that a lot of you have been doing for years, which is putting one 11 VBX stent in, a balloon expandable, into the aorta to get nice expansion and laminar expansion on both sides. And once that nicely opens up, then going in with 2, usually 9 or 8, depending on your bifurcation, stents in through the iliacs, and then ballooning everything. The reason this is nice is because you do that, get that nice coverage, and you are protected to some extent. It acts almost like an EVAR in that you've got seal above and below. You do have that period of time, though, where usually, I'll put in these patients, because they're pretty tight, an 8L VBX, so then I'll post-dilate. And it'll sit. It's not going to fall anywhere because it'll be right there. But you, at that time when you balloon, could in theory rupture and not be protected. But then you would quickly go in and put in your bilateral 9s, and you would then be able to seal as long as you haven't really ruptured the whole thing. This is really good in terms of expansion and excellent data for long-term data now, which I'll show you in a second in terms of the patency, but you've lost your bifurcation, right? Obviously. And so that's problematic in these patients. So the reason I put this on here is what's the point of the 11 is just to tell you that it was to protect against that ultimate rupture risk, which did not happen, luckily. And then, great result on her. I did want to say that the reconstruction does have now very far out patency data, and it's excellent. Nobody really questions that. I have had one patient where a limb went down, and it had to do with the way that the crossing was, and I basically missized internally. I should have put smaller ones. I figured just because I had an 11, I could put whatever in there, but that wasn't the case because what happened on the distal iliac is that it was a little bit tighter, and I should have gone with a 7 or 8 instead of what I went with, and not just measured to the bifurcation, which was the mistake. Now we're talking about the AFX Endologics device. So this is actually kind of the way and has been the way for a very long time. 2 big things with this device. One, it's going to preserve your bifurcation, which is amazing, and people love that. And there's 10-year experience and multiple users who use this device. What has happened, though, with younger people, I'm going to count myself in that. I do dye my hair. But with younger people, we just don't have that much experience. People, AFX triggers, it's a triggering word. so we don't use it as frequently. However, in talking to the reps and in getting prepared for this talk, turns out that the majority of the United States uses AFX devices for aortoil-occlusive disease, not for aneurysms. So that's quite interesting to have found out. And so, and the beauty of this is that apparently it's irrelevant what the size of your bifurcation really is. You can go, as long as you can get your sheath in, you can do it because it's the uni limb, and then you just snare and go up and over. And so this is a wonderful way to take care of things and keep your bifurcation. And I think nowadays more than ever, maybe this is going to make a comeback. I will tell you, though, in the last 5 seconds, that there are 2 companies out there right now that are working on devices specifically for this phenomenon. And whether or not there'll be enough of a market share to get to market, I don't know. But it's something that is going to happen as the next steps. Thank you so much for your time.